Thank you so much to everybody so far who has been tuning in. Next up, we have Dr. Howard Liu. Howard is a psychiatrist and educator, workforce expert, social media innovator, and healthcare leader at the University of Nebraska Medical Center. Dr. Liu.
Honored to join you. Thanks so much, Mark.
Thank you for taking the time. I really wanted to make an effort to make this a cross-border, even a global event this year. I think Bell Let's Talk Day has spanned the globe in past years. So to be able to include some more new people like yourself is really an honor. Tell me about your work at the University of Nebraska Medical Center. What are you focusing on there in the mental health space?
Well, I'm lucky enough to be the chair of psychiatry here. So I work on really creating access for mental health programs. Most recently, we just opened up a new psychiatric emergency services. So that's been a lot of our efforts.
Now, we have coming up on the show right after you, Dr. Catherine Zahn, who heads up the Center for Addiction and Mental Health here in Toronto. They were I believe, the first, she can correct me if I'm incorrect on this, but the first psychiatric emergency room in Canada, dedicated emergency room, that is. So tell me about your experience there. Why is it important to have specific emergency services for mental health crises?
That's a great question, Mark. And by the way, I appreciate your courage in sharing your experience as a survivor of suicide as well. And I think that what we thought when we were going about this process was that we saw an increasing number of people coming in, mostly adults for our ED, in crisis, and it had roughly doubled over the last 3 years. And many of them were telling us that the busy and traumatic ED was just not a healing place for them. And they oftentimes avoided coming in unless they really needed it, thus delayed their care. So when we went around this design process, we visited and talked with several experts nationally, and also made sure that we included some peer professionals with lived experience in the design process. And then we really honed it down to two models, one from Alameda County in California, one University of Michigan, and really our psych emergency was designed around those two centers.
So now what should people expect or what should they be prepared for if they do need to go to, and I'm sure they're different depending on where you go, but generally, if they do need to go to an emergency room, specifically a psychiatric emergency department, what should they expect and what should they prepare for?
Well, I think that they should expect to be treated with dignity and hopefully a compassionate space. And I think that's so important because, this may be the worst day of somebody's life, right? They're coming in, might be the anniversary of a trauma, might be when they had nearly ended their life by suicide earlier, and some of those echoes were coming back from depression or anxiety. So I would say the first thing is that dignity has to be built in the process from check-in all the way to treatment. The second thing we want to make sure is that many of our patients were telling us that in normal emergency rooms, they felt like they were sort of warehoused, so they might have been briefly evaluated, and then were literally confined to a room for sometimes days on end, which we thought was really the opposite of what they needed. So we want to design an open space for people in crisis so they could walk around, talk with other people who are maybe going through similar pieces in their lives, and then also interact with peer professionals that had walked this path before and have immediate access to 24/7 therapists, psychiatrists, nurses that really were trained in this area.
Mhm. Now, the World Health Organization has identified the use of seclusion and restraint, particularly in mental health settings, as not particularly therapeutic. So how do you tackle this issue in your own emergency department, the use of seclusion and restraint? And how do you train your staff on using alternative methods?
I think that is so important. I think that one of the great innovations over the last 10 to 20 years is this movement towards patient advocacy and being patient-centered. None of us would like to have ourselves or our loved one in restraints. And if it ever was applied, we need to make sure it is for the least amount of time possible. So all of our staff are trained in crisis response. We deliberately hired, and we had the luxury of hiring a brand new team of about 40 people to staff this ED to make sure that they really believed in that philosophy. And I do think that having peers on the team, peer professionals, really helps because it's not like you just bring somebody on for an occasional committee. They literally are part of the team meetings and they're shaping that discussion. And so we want to make sure that everyone from security to the front desk staff are trained in this.
Now, I want to address, since we brought up this issue of training around medical education, and consistently, I observe this myself as a patient who went through general hospital emergency rooms for psychiatric reasons, and I experience this as a clinician going with clients through emergency rooms as well. That those can sometimes be the worst places for mental health stigma. When it might be the 20th person that triage nurse saw that day, but it's your first time, and this is the most traumatic time of your life going through this time. So then, how do we actually break down the stigma among mental health professionals and healthcare professionals more broadly, so that they treat each and every patient as a human being who's potentially at the worst moment of their life?
I think what you're describing is really a gap that arose between the so-called medical model, right, and the recovery movement, which is really a patient advocacy movement. And my thought is that as we go ahead, and by the way, we also started a new residency program this year for adult psychiatry and also addiction medicine fellowship, trying to make sure that those principles are part of the curriculum.
Mhm.
And it has to really begin on day one. If we train people to see, look at algorithms versus individuals, that is the wrong approach. We certainly need to have evidence-based treatment, but there always has to be patient autonomy, and patients have to have that choice. So I think it really goes back to the philosophy of a training program. And I do think that, to your point, there has been too long a gap between what patient advocates have asked for and what training programs have done. I believe that gap is narrowing now, but there's still plenty of work to do.
There certainly is. So I look forward to seeing the work that's happening at the University of Nebraska, and I really thank you for your work here and also on social media as well. You've been, like Dr. Gold before you and a few other people we've had on the show, you've been very active on social media. So let me ask you, just as our final question here, what is the importance of social media for you as a psychiatrist to put yourself out there and talk about some of the professional issues you've been facing?
Well, I believe that the modern psychiatrist needs to be a community psychiatrist. And what that means is not that we wait for people to come to our office, but that we are out there in our local neighborhoods, working as advocates for social determinants for children in our neighborhoods who are struggling, working with elected officials to improve conditions for access, and also on social media, which is like a global community. And I feel like that is where we can really do the most good by clarifying misconceptions and also by answering questions honestly. And clearly, there are a lot of gaps. We can't cure everything right away, but we need to make sure we own our past mistakes. One thing I've seen is, for example, the American Psych Association just put out a statement really apologizing for its lack of action on racial inequities in the past. So I feel like part of it is ownership, part of
Mhm.
it is accountability, but we can also listen. And I've heard from literally thousands of people now on social media, many patients, many advocates, many families, and that's so important.
Yeah, I saw that statement that the APA put out, and I think it's that on its own is an important piece of public health education. That science is supposed to change and evolve, and that psychiatry, of course, some people think that it's strange that diagnoses have changed over time, or the APA has taken different statements on different positions on different things over time. That's the way that it's supposed to go. I would hope that they continue to evolve and recognize, like you say, when they fail people. So I thank you and for everybody in the profession for speaking up and moving it forward.
Thanks so much. So thrilled to join you.